You can go ahead. Welcome, welcome. It's good to have you guys joining us for the CalMap webinar today. I'm Dr. Lauren Schumacher, and I'm one of the CalMap consultants that's on our education team. And I'm very excited to have Dr. Cox with us today to talk about beyond ACEs screening, how to prevent, screen, and manage pediatric traumatic stress in primary care. Dr. Cox, MD, PhD, is a child and adolescent psychiatrist at UCSF, providing consultation for CalMap and clinical care in outpatient psychiatry at UCSF Benioff Children's Hospital in Oakland. He also spearheads CalMap's efforts to support mental health education for pediatric trainees and training program faculty. Dr. Cox completed residency training in pediatric psychiatry and child and adolescent psychiatry at Tulane University in New Orleans. He completed medical school in the physician scientist training program at the University of Kansas School of Medicine, and his primary interests are in integrating behavioral health in pediatric primary care and early childhood trauma. We're very happy to have him today.
Thanks, Lauren. Go ahead and jump in and say, that we don't have any disclosures, financial disclosures to make. And we have our sources of funding for CalMap, which is primarily through HRSA and DHCS. And again, thank you all, like Lauren said, thank you all for being here and really excited to talk to you about this topic. It definitely something I'm really passionate about and see it as an area for growth that we can impact more kids' lives through primary care and helping kids in that setting who are dealing with traumatic stress. So the title was how to prevent, screen, and manage, and it sounds like a lot, and it is a lot, but it is something I really believe strongly that we can do. We can do this in the primary care setting, and to get to that point or feel comfortable doing it and confident doing it. These are the objectives I hope to accomplish through this talk. So that is first I hope we can all differentiate core features of pediatric traumatic stress from other mental health conditions. So how we can distinguish it and identify it. And then secondly, along with that, know about tools that you and your clinic can use to prevent and identify pediatric traumatic stress. So some really things with really good evidence that we can use to help us in this process. And then thirdly, how to triage for symptom, severity, and functional impairment to know what level of intervention is needed after traumatic event. And then finally, how, I will hope to provide you all with a lot of resources for yourselves and for families that can help us do this work. So at the end of this talk, I think if we accomplish these objectives, then we'll feel comfortable and confident to start doing these things, or to hopefully the other alternative outcome, which I would love, is if you're already doing this, to feel like you're doing a lot and to know that you're doing a great job, and that we can hopefully be able to continue doing that. So to start out, I want to give some acknowledgments. A lot of this work is based on work done by Brooks Keeshan, who's a child abuse pediatrician and child psychiatrist at the University of Utah, and their group at Intermountain Health, who developed this child traumatic stress care process model, which is really evidence-based and a lot of research into how do we take care of pediatric PTSD in the primary care setting. And there's also a lot of resources in here from AAP, Council on Child Abuse and Neglect, and from the National Child Traumatic Stress Network as well. So we'll be sharing those and just have to acknowledge those and their great work that people have done in this area. So let's start with a case example. And this is very similar to a case that I was called about when I was doing consulting for CalMap. A PCP called and said a 7-year-old girl had come into their office. They were aware of them, knew that they were in foster care, and had established care through their new foster family. And the plan had been to adopt this child. But now the foster parent is presenting with the child who with the chief complaint of being really, really angry, not listening very well, and had questions about does she have ADHD? So the additional history that the PCP shared is that this young girl was placed with her brother in this foster home about 6 months ago. And maybe there was a honeymoon period. Things were initially going well. She was kind of shy, but really sweet. But over the last couple months, her mood has been going really up and down, and she's never sitting still. She still has moments where she's really sweet and cuddly, but other times where it just seems like not herself, like she's a different person. And the other thing that's been happening is she was having a really hard time going to sleep and seeming really afraid. Initially, she was sleeping with the foster parents and they're just kind of getting acclimated, but they're trying to separate and going through the bedtime routine, and it's been going really poorly. And she's complaining of belly pain and leg pains around bedtime as well. And it started to affect school too. There's been a couple episodes of aggressive behavior at school, hitting her head on the wall, and at home, the parents noticed a couple episodes of aggression too, associated around bedtime routine when they noticed that when they closed the bathroom door, she seemed to get really, really upset. And the PCP got the impression from foster mom that she just didn't know if she could continue caring for her. And because of the impact all these things are having on the younger brother, on the parents' relationship and their home, and wanting help. So we'll come back to that. And I know that's the kind of feeling when we see that kind of clinical picture, it can feel overwhelming. And what can I do to help to try to keep this kid in this home in a stable situation with loving parents? How can I help them feel better? And that's where we're going to get to by the end of this talk, and we'll come back to the case then. But the first part is, what is going on with this kid and kids like this? And, because this is a talk on traumatic stress, we already kind of know, but we want to talk about what traumatic stress in kids can look like. Because, our classic, we've been using the word, sometimes we use the word PTSD flippantly, and we think like, wow, that line at the DMV really is going to give me PTSD. But of course, we know it's a real thing, and we typically associate it, for a long time with soldiers returning from war after experiencing trauma at war. But now we know that it definitely occurs. It can occur after any serious traumatic event, and it can definitely and occur in children as well. And so the two things that we need for a diagnosis of PTSD are a qualifying traumatic event and then symptoms that we'll go over in just a second. But the traumatic event is, there is kind of specific definition. It can encompass a lot of different things, but really what you're looking at is something that causes or threatens significant or serious life-threatening kind of harm to a person or to a loved one that they witnessed or heard about or were told about repeatedly in detail. And so, we might think like, how often does this happen? The data is that around 80% of people will experience a qualifying traumatic event at some point during their childhood. So let that sink in. That's 80% of kids at some point during childhood will experience a traumatic event, and many kids will experience multiple. So that's a lot of kids, a vast majority of kids. Now, the good news is that about 15% of people who are exposed to a traumatic event will then go on to develop PTSD. So that's still a significant amount. And especially when we're talking about 80% of people, 15% of those going on to meet criteria for PTSD. But it is a minority. Most people, after experiencing a traumatic event, will recover. They may have symptoms initially, but they will recover from that within the next few weeks. But there are, again, a significant minority that the symptoms don't go away and they continue or pop up later on after the event and meet criteria for PTSD. So what are the symptoms we're talking about? And really it's stuff that's related to intense emotional physiologic distress that follows after a serious traumatic event. And we put them into 4 different categories. So one is intrusive thoughts. And that can be things like flashbacks. We don't often hear that, term from kids, but can describe that. It's a lot more oftentimes it's things like seeing how they are playing and playing out traumatic experiences in their play or constricted play. And really often a common way it presents is through nightmares, either an increased frequency for young children after a traumatic event, or an increased frequency, and for older kids being able to tell you that the nightmares are related to the event. The second category is avoidance. So this is avoidance of being around or talking about things that remind them of what happened. So you think about like a kid who's been in a serious car accident, now having a really hard time getting in a car or being in a car and in traffic. That's an example of avoidance. Of course, young kids can't really avoid, they're not in control of where they are, parents taking them from place to place. So it could be more of like distress around and emotional dysregulation in places that remind them, or around things that remind them of the trauma. The other category, a third category, is hyperarousal. So hyperarousal, again, can vary by age and look like a lot of different things. Sometimes, especially in older kids, it can just look like fear and anxiety. And that may be what we think it is. Just is it more generalized anxiety? But it's typically more, and it can be kind of generalized and throughout, but it's a little bit different than worry. It's a sense of fear. And what another thing it can look like is more general irritability or anger. And of course, if someone's on edge and irritable and afraid, you might imagine that sleep would be really difficult, and that they might have a exaggerated startle reflex. So these are all things that hyperarousal can look like. And then the fourth category is a little more difficult to define sometimes. So when we just see the term negative mood and thoughts, like what does that mean? Is that depression? And the way I think about it is that there is this general overgeneralization of themselves or their world around them after a traumatic event. So, for instance, someone does something really bad to them, then they start to think, I am bad, something is wrong with me, and they're blaming themselves and feeling really guilty or really self-critical. Some of that could be negative thoughts, negative mood. And then, again, go back to like a car accident example. Someone's in a car accident, could be this overgeneralization that all cars are dangerous, all traffic is dangerous, when, and it is a little bit, but the truth is they're, pretty safe, but they don't feel that way. And that's could, qualify as a negative thought as well. And these are all, symptoms and what they of PTSD. And for the diagnosis of PTSD, the symptoms need to be present for, and in all of these categories, for longer than 30 days. When it's shorter than 30 days, we call it acute stress disorder. Like I said, most people may have some of these symptoms or all of them, and they'll resolve over the next few weeks after the event. But for kids that they continue, these are the kids that we need extra help. So, as I talked about the core symptoms of PTSD, you might have noticed that it looks like a lot of different things. It can look like a lot of different mental health problems as well. The negative mood and blaming themselves and I'm a bad person, that looks a lot like depression. The constant fear or being on edge and irritable and poor sleep, that looks a lot like anxiety. And sometimes, especially younger kids, that fear and irritability and anger can look like defiant behavior and even sometimes conduct disorder. And then the avoidance, we know that substance use is really common way to try to avoid negative feelings, and same with self-harm a lot of times as well. So those can definitely be how it initially presents. Suicidal behavior as well. I mean, it can look like ADHD with kids being difficulty time sitting still, acting more impulsive, trouble focusing. And then, like I mentioned, insomnia can be the initial presentation. So when we see any of these things, it's important that we ask ourselves, has there been a recent trauma, or is there a trauma that I don't know about that could be part of the picture of these symptoms? And that's what we're going to talk about here in a minute. First, we're going to focus on prevention is the first step that we talked about and how to care for PTSD in primary care. And prevention is something that, we're great at in primary care, and you probably are all doing already, but it's basically, just so I won't spend too much time on this, but basically the most important part is screening for risk factors and addressing those risk factors as you identify them. So we know that certain things are related to and correlated with increased risk of experiencing a traumatic event like child abuse. And those are typically stuff going on with their parents, right? Like intimate partner violence, mental illness in parents, substance use in parents, but other environmental things as well, like financial stress, housing instability. And so knowing about these things and screening for them can help us prevent, future traumatic events from happening as we address them. I mentioned a couple tools here. This is one, the Safe Environment for Every Kid, I think is a really great tool that we used in my pediatric residency, where we'd give it to every well child visit, and if anything popped up, we would check in with the social worker in the office, who would meet with the families and point them towards resources in the community that could address whatever issues they were having. And so screening for, we want to have a plan, what we're going to do if anything comes up positive. So knowing about community resources really comes into play for parents, for their mental health, for, financial and housing instability, wanting to have things ready to go to point parents to, families to, as needed. But it can have a big impact and is a really important part of this care that I know you all are doing. And then the second part is picking it out. So this is where knowing the core symptoms is important, but also, screening and how to screen and why to screen and when to screen is it can be helpful too. Because are we just waiting for kids and parents to come in and tell us that they've had a traumatic event, or that, they have a complaint? I think that we're doing that, there's going to be a lot of kids that we miss. So when do we screen? When is it? And why would we do that? And in general, there's some differing opinions in this area. Should it be universal in every single visit, every single well visit or sick visit, for any kid of any age, versus reserving it for specific populations? I think it could depend. If you're serving a more at-risk community, kids kids who are in vulnerable populations, like in foster care, have developmental delays, have housing instability, or immigrant families or refugees, then definitely universal screening is preferable. But even if you're not doing that, and you're not sure when else to do it, definitely doing it with any behavioral health visit is really important. And then screening for symptoms after a known trauma exposure is really important too. So that's when I'll advocate for screening. I think you can do it universally, especially I think you'll feel more comfortable doing it universally after you know about what you can do to help, how to triage, what kinds of interventions are helpful. But if you're not to that place, please do it at least for if you're serving at-risk people in at-risk populations, or for every behavioral health visit. And then why we do it, of course, is sort of, it goes without being said, but it's to identify kids who may need treatment. Not every kid is going to need treatment. But if we don't know, we don't ask, we don't know, then we're not going to know who does need treatments. And, we're going to miss the kids that were fine and we're going to recover on their own, but we'll also miss the kids that could have benefited from our extra help. So how do we screen? What tools do we have? The Pearls is an excellent tool for screening for traumatic events. I think I've learned more and more about this as I've come to California, and I think a lot of places are already using this screen. There's, of course, a parent version for younger kids, a teen version, a self-report teen version, asking about adverse childhood experiences, some of which wouldn't, qualify as a traumatic event that could cause PTSD, but many of which could. And of course, as we know, ACEs have proven impact on health, and so it's important to know about these things as their primary care doctor, so you can look out for the impacts on their health. But it's also helpful for screening for, do they have, could they have, do we need to ask about symptoms of traumatic stress? And, and that is something that the PEARLS does not do. It does not ask about symptoms of traumatic stress. So I think it's a wonderful tool, and definitely encourage continuing to use it if you're already doing that. But I'm going to tell you about some additional tools that we can use to help us ask about symptoms, because I think that's a really important next step. Like I said, 80% of kids are going to have most of our kids are going to have, positives on these ACEs screenings, but not everyone needs intensive intervention. So which ones do? I think that's where it's important to ask about symptoms. This is another tool if you're not using the PEARLS, or you're wanting to also screen in a different way and also ask about symptoms. This is another tool that was developed by the Intermountain Health Group that I mentioned earlier in the care process model. It's called the Pediatric Traumatic Stress Screening Tool. It's a validated screening tool for PTSD in kids from ages 6 and up. And there's a caregiver report for younger kids, kind of like the PEARLS, and a teen self-report for older kids. The top of it is just 2 questions about trauma exposure, and it's different in the PEARLS. And I think there's pros and cons of different approaches. This is a more open-ended. Has something recently happened? Has something happened in the past? And if yes, what? There's a space for them to say. I think the nice thing about that is that you may catch things that may not on the PEARL screening, that are all still significant and traumatic. But the downside is that, sometimes they're not seeing something as traumatic or scary or upsetting necessarily, unless you're asking specifically. So the PEARLs can work well with this tool. But the first 2 questions are about trauma exposure, but after that, the next 12 are about trauma symptoms. And they're just symptoms from those core categories I told you about earlier: hyperarousal, intrusive thoughts, avoidance, and negative mood and cognitions, and in giving you a sense of the severity of those symptoms. And it's available in English and Spanish. It's freely available. You can easily Google it and find a PDF version. And definitely, I think it's a wonderful tool that you could consider using. And we'll talk about how to use it in more for triaging in a minute. But it could also be used for identifying if you're not using something already. And then for younger kids, I mentioned that the PTSST is validated for kids 6 and up. For younger kids, we honestly don't have a lot of great tools available in the primary care setting. And could use the SEEK. It does ask about some potential trauma exposures for kids age 0 to 5. So if you're doing that to screen for risk factors, you're already asking about some potential trauma exposures as well. So that's another advantage of using that. But it doesn't ask as open-endedly, but the PEARLs may be another good option to use with parents for younger kids as well. All right, so now we're preventing as many cases as we can, and we're identifying cases that have happened. And then the question is, what do we do with that? What do we do with that information? And then finally, how do we help? So the first part is triage. And I think about this a lot like with suicide assessment as well. So suicide is another really scary thing when the kid reports suicidal thoughts. And we often wonder, afraid to ask maybe, but now we ask and now we know. And now I wonder, what do I do? And it's scary and it's intense and it has a big impact. So does every kid needs to go to the hospital? Can some kids go home? And so what you do is you try to assess for risk. And for trauma, the first part of assessing for risk of PTSD is addressing safety. And I really like this image, this triangle over here on the right, which is the kind of visualizing this 3 stages of trauma recovery. And the first stage, the thing that has to happen for kids to recover from a trauma experience is a stabilization, is safety. So, if that is all you're doing, you're assessing for, are they safe? Is exposure ongoing? Then you're helping them recover from their traumatic experience. If families are giving them a safe home, are helping them feel safe and stable, then they're helping them recover from a traumatic experience. So there's a lot being done in just that safety and stability. The next phase, but can be happening at the same time, is trauma processing. And this is something that, when kids are talking about what happened to them, when they're doing it in their play, even when they're having their nightmares, they're processing what's happened. And this is something that parents can help kids do. You as their physician can help kids do. But they may sometimes need extra help from a professional, mental health professional, to be able to do this part. And then finally, the final step of recovery from a traumatic experience is reintegration. And that's just getting back to and into life as it should be for them as a kid. And this is, again, another thing that you can help them do, that parents can help them do to recover. But the first part of triaging, and go back to the bottom, is stabilization. So addressing safety. And then the second part is asking about symptom severity and functional impairment. So addressing safety, really, you all are already doing this. It goes without being said. If we suspect abuse or neglect, then we need to report it. And I put a link here to our CPS county reporting hotline. And beyond that, if the answer is no, they're now safe, they're in a safe environment, the next question is there suicidality? So the last question of the PTSD asks about suicidality. You may be using other screening tools like the ASQ or the Columbia, or you may be asking in the PHQ-9, or you may just be asking in your HEDS assessments. But it's important that we're asking somehow. And if positive, that's when we're taking a detour from triaging and addressing the trauma-related symptoms, and we're addressing the suicidality, because that takes priority in this case. So if positive, we have some awesome, I won't spend too much time on this. We have some awesome tools on our website. I know there's been other webinars on this topic from CalMAP on how to assess for suicide risk and ensure safety, and in doing that assessment, tools that you can use, including the Columbia Suicide Severity Rating Scale, the Brief Suicide Safety Assessment. All that stuff's available on our website. You're putting kids in different categories, low, medium, or high risk, and you're doing different things depending on what category they're in. But that's an important first step. And then after that, so let's say they're safe, let's say they're not suicidal, then you're going on to the next step, which is to get a sense of what is the severity of symptoms, if any are present, and then what is the severity and what is the impairment. And this is something that you can ask the questions about symptoms. You can ask all those, core symptoms I told you about. You can try to get a sense of how severe they are. That's really what I do most of the time, because I have the time. But in a primary care visit, I know we're pressed for time, and we don't, necessarily do it enough to know, what are the questions I'm supposed to ask? How many, did I forget that group of symptoms? So having a tool to use can be really, really helpful. And this is, again, where this PTSD tool can really come in handy, because it, in a standardized, validated way, asks about symptoms of PTSD and gives you a sense of severity. So, so those 12 questions, those questions 1 through 12, are the symptoms, and they're in a scale of basically 0 to 5. And for kids who are in the score of 0 to 10, so you can just add them all up, or you can just look at it and see, like, most of the scores on the left side, then it's probably mild or no risk of PTSD. Or if they have if you do add it up, if it's scored to 0 to 10. If the scores are mostly in the middle, you just eyeball it and see they're most, kind of little or some of the time responses, then it's probably a moderate risk for PTSD. And for kids whose responses are on the right side, then with much of the time or most of the time types of responses, then they have a high risk of PTSD. And we'll talk about what you do once you know the risk. But the first part is understanding and triaging the symptom severity. In addition to symptom severity, though, another kind of category that usually goes along with symptom severity, but sometimes can be a little different, is functional impairment. So some kids can have sort of more mildish symptoms, and reporting that, but have more significant, moderate to severe functional impairment. And then the reverse can be true too. Some kids can be reporting higher symptoms, but they're doing pretty well and at home, socially, academically, and their health. So that can influence what different kind of intervention you do. And so that's why it's important to consider that as well. So now we get to the part about intervention. We've prevented as many cases as we can. We've identified cases that have happened. We've addressed safety issues first, and we've got information on how severe symptoms are. And from this information, we can take that to develop a plan to intervene and support. So the intervention part I have broken down into two different tiers. Level one is you know the simplest form is just education, and that include psychoeducation and anticipatory guidance for families and teaching about emotion coping skills. So that sounds overwhelming. Like, how am I supposed to teach families about PTSD? I don't know if I know enough myself. How do I talk them through it? They're asking questions. How do I support? But this is where these resources, provider resources and family resources really can be helpful, because you don't have to do this on your own. You don't have to know all of this information and be able to and have the time and knowledge to be able to talk through all of this stuff with families. We can use the resources and things that people have made that are really, really high quality. So the National Child Traumatic Stress Network has wonderful guides and handouts for parents and families. Two I listed here and have links to here. One called the first one called Understanding Child Traumatic Stress, a guide for parents, and the second one, Age-Related Reactions to a Traumatic Event. And essentially, it's kind of doing what I'm doing with you all today a little bit, helping parents understand the core features of childhood traumatic stress and how they can how they can help their kids who are experiencing those symptoms. And and these tools are really straightforward and simple, and I'll show you an example of one next. For the AAP's parenting website, healthychildren.org has also a lot of great articles on PTSD, and they have some videos that are like 2 minutes long, can explain PTSD to parents and how they can support. And this level of intervention, just providing the education and guidance to families, is a huge, huge part of the recovery. I told you that the stabilization, that stability and safety, but it is important. And so some of that is teaching about, how important is routine, how important it is to continue doing things as normal and making kids feel safe. But the other part is that symptom processing, processing the trauma, and that's something that parents can help their kids do as well, if they know how to. So this step is really important, and these are some resources that you can use. And then beyond that, teaching kids and demonstrating emotion coping skills is another thing that we can do. Sorry, skipped forward. Is another thing that we can do that's really helpful. So if you're able to yourself demonstrate, you have a couple favorite things like belly breathing or progressive muscle relaxation that you can do real quick. Say, hey, this is kind of how, when I feel upset, this is what I can do to help myself feel more calm, to teach parents. But what really helps is giving them information so that they can learn about it at home and help their kids do it when they feel upset. So we have some great videos on the CalMap website that this link goes to. If you look under provider resources, under trauma, there's some great videos on these different coping skills that kids and parents can learn. And this is another place where I really have to make a plug for the other Cal Hope programs, Saluna and Bright Life Kids. So if you don't know about these, are really helpful tools, new free tools out there. Saluna for teens, and it really is really well vetted information on how to cope with emotions, on all of the stuff that we're talking about today, understanding guidance and psychoeducation. And Bright Life Kids is another great source for parents of young children who are wanting to know how they can help kids help their children through after a traumatic event. They can sign up to get a coach that can help give them some of this guidance and more intensive support. So this is a really great, really great resources to use in addition to some other guides above and some things that you can teach kids and families. And here's an example. This is from the Understanding Child Traumatic Stress Guide for Parents. This is the second page of that. It's really only one page front and back. And it's just, the steps of what parents can do at home to help their children who've experienced a traumatic event. So one, learning about common reactions that children have to traumatic events. And we talked about that earlier. So knowing the symptoms for yourselves is good to identify, but it's also good so that you can teach parents so that they can understand and have empathy and patience. Know when to ask for help. We're talking about that today. When we're talking about triaging, helping parents triage. When do I ask for help? For them, it's if they're having symptoms at all, ask your doctor about it. But if they're beyond a few weeks after the event. And then, the bottom of that pyramid, assuring that your child, his or her safety, assuring your child of his or her safety at home and at school. So talking with them about what you've done to help make them safe at home and keep them safe at school. Reassuring them that they're not responsible. So again, a lot of kids will blame themselves as part of the symptoms of PTSD. So parents can sort of combat that negative cognition and help them overcome that. Allowing kids to express their fears and fantasies through play. This is that processing step of recovery that I talked about, and this is what they do in therapy, but this is what parents can do at home as well. They don't have to have a therapist to be able to do some of this work. And then number 6 is that goes down to the bottom of the pyramid, the stability and safety. So maintaining regular home school routines is really important, but it also helps with the top, the reintegration. So going back to school, like staying in school if we're able to, getting involved in activities as much as we're able to can really help with the recovery process too. And then finally, this is something I didn't really talk as much about, but the time course of this can really vary. So some kids, as I mentioned, only 15% will continue to have symptoms beyond a month and will qualify for a diagnosis of PTSD. But how long does that last after that? And really, there is no right or wrong time course. Some kids, it really lingers a long time. Some kids, it gets better, and then it can get worse around trauma reminders or certain times of year or triggers or stress. And so parents understanding that can help them be patient and help them to continue to do the other steps in this process so that their kids can recover more quickly. So as you're gathering this information and communicating with families, how we communicate really has a big difference as well. So I really like the AAP's HELP mnemonic, which the H stands for hope. So expressing hope, like this is going to get better. We're going to help you. You're going to feel better. I know this is really hard, but we're going to get through this is contagious and can be therapeutic by itself. Expressing empathy to the kids and their parents, like this must be really hard to see your child going through this, can have a big impact on them and how they feel and how their capacity for empathy for their own kids as well. Using their language can help show that you understand what they're saying and that you're with them and you're part of their team. The loyalty piece that goes along with that as well, like I'm with this through you. I'm going to go through this with you, and we're going to do this together. That can help them not feel so alone and be able to get through it, continue on. That partnership, asking them what they think is going on, what they think helps, what that doesn't help, what they would like to try, helps them feel a sense of autonomy and build trust and that you're, again, a partner with them in this. Asking permission also helps with that, and coming up with a plan. So even if we're going to come back in 2 weeks and we're going to continue to assess these symptoms to see if they get better, or if we're going to read about or learn about what are normal reactions to stress for kids, what are the possible reactions, and how to get through that. So just education. Or if I'm going to point you to these coping skills, and we're going to see which ones work for you, and come back and tell me how it's working, and then we'll go from there. So just some kind of plan of what we're doing now, what's coming up next, can help people feel like things are moving forward and that can be therapeutic too. And all of this is done, we're communicating this way with parents so that they feel supported and listened to, and hoping that they then can share that process, use these skills as well with their own children. Okay, so we've talked about level one. Okay, and I'll get to when we use level one, when you use level two. But level one is education and coping skills. Level two is asking for more help. And that is referring for really, we'll talk about, a medication, but really the first line of intervention is for therapy. There are evidence-based treatments for PTSD in kids, and there's several. I listed a couple here: trauma-focused CBT, child-parent psychotherapy. But the common components are that they're developmentally and culturally sensitive, that they're based on resilience and safety, building skills. They're helping kids overcome avoidance of the trauma experience because we know that that reinforces the symptoms, and the exposure can help them overcome those symptoms. And they all involve a parent or caregiver as much as possible, because a lot of this work isn't just going to be done one-on-one with a therapist, but is going to continue on at home. And so a lot of it is about continuing that education and that support of the caregiver so that they can do all this work when they're with their children. So, referring for help is sometimes needed. And I know that evidence-based treatment, evidence-based therapy, finding trauma-focused therapy or child-parent psychotherapy can be really, really challenging. And depending on where you are, the resources of the family, the time you have, everything like that, what type of insurance. So there are other times when we'll take what we can get. We'll take any kind of support. And there's other types of support sometimes that we may have access to that could be warranted. So I list a few here: parent-child interaction therapy and behavioral parent training. Behavioral parent training is basically a group-based format of PCIT, but that just involves the parents and not the kid. But these can be really helpful for kids who are having really big behavior problems at home, whether related to PTSD or not. But if it's related to PTSD, this type of therapy can be really helpful for parents to know how to help kids with those behavior problems in an effective way and a safe way. PCIT actually is more than any other type of therapy has been shown to reduce risk of experiencing child abuse for kids who are at risk. It can be effective for those families who are at risk, but also even for families who have experienced, or kids have experienced trauma, and they're having specific types of behavior problems at home. Therapeutic behavioral services and wraparound services are other kinds of more intensive types of support for families, specifically that have Medi-Cal insurance, that we sometimes are using when we're just working on the stabilization part. We're not really working on the processing part. We just need to keep things safe and stable at home. And these services can sometimes help with that process, where providers are coming out to the home, doing more intensive support around behavior problems at home, at school, coordinating services for kids who have a lot of different things going on. So these things you can consider if either we don't have trauma-focused types of evidence-based therapy available, or if we have more things going on and we're just working on stabilization. Okay, so this looks like a busy slide, but it has everything essentially that I've talked to you about up to this point. So if we just have one overview slide, this is it. And this is basically the process of how to care for PTSD in primary care. And it's adapted from the care process model, but it starts with identification, right? If we don't, of course, I'll go one step above that with prevention above this slide, but after that, it starts with identification. So knowing that there's been a trauma exposure, and we talked about tools that are available for that. The PTSST, the pearls. We ask about trauma. Have they experienced it? If yes, then we ask about, do we need to report it? If yes, take a detour from this pathway and report it. If there's suicidality, take a detour from this pathway and work up a suicide assessment and risk. If no to answer those questions, then you go on to symptom severity. And again, you can use tools like the PTSST, or you can ask these questions and try to get a sense for yourself, your own clinical judgment. Are there any symptoms? Are they mild? Are they moderate? Or are they severe? And letting functional impairment influence where you're categorizing kids as well. But for for all of these kids, level one, or we should be doing level one types of interventions, and that's the psychoeducation, anticipatory guidance, and emotion coping skills. For kids with more moderate symptoms, we want to be doing that plus referring them to some kind of therapy. We'll take what we can get. It may be brief, maybe integrated behavioral health, it may be non-specialized, a school counselor, but some kind of support, additional support, so that you can help with the processing step and help with the education step for caregivers. And then for kids with more severe symptoms, we're trying our best. Again, it can be difficult and it may be hard, and we may have to take what we can get, but we're trying our best to look for evidence-based therapy for trauma, because we know that works, and we know that can help kids who are experiencing these things. So some quick caveats to that clinical pathway. For young kids, it's a lot harder to make the diagnosis because their symptoms look even more like everything else. So if there's a trauma exposure and any kinds of symptoms, new symptoms, behavioral or mood related, that's when I would be making a referral, so that someone else can just help us figure out what's going on. Is this related to the trauma or not? And do we need additional help? And use your clinical judgment. Different types of trauma, different types of symptoms can influence, does this kid need therapy or not? Other things that can influence it as well are barriers to care, presence or absence of protective factors, different resources in the family, and the parents' kind of level of understanding, attunement with kids, and their own capacity to support may influence what kinds of additional support you're asking for. All right, and now the last thing, I haven't really talked about medication, and that's not really on accident, and it's because really unfortunately there's no evidence for first-line use of medications for pediatric PTSD. We've tried, and we just haven't found anything that's consistently better than placebo. And what can happen actually is we're trying our best to help, and we have medication tools available. This looks like anxiety. Could it be? Let's try an SSRI, and it can escalate from there. And so one group that we know this happens and is foster kids. They're 4 times more likely to be prescribed a second generation antipsychotic, and they may have reason for having that, but many of these kids, the likely situation is that they have PTSD and may have other things going on as well. But we're trying to use a medication that isn't an evidence-based for that, other than just helping sedate them, and has significant side effects in addition to sedation. And then, like I said, the other thing it's difficult is that symptoms look like other things. So like I said, it looks like a lot like depression. It can look a lot like ADHD or anxiety, but the underlying mechanism is different, and so may have a different response to treatment. I was saying all that, but there's a big however here, okay? A big but. Comorbid conditions are also common. They may have had something underlying. They may have something in addition to trauma-related symptoms. And medication can sometimes be helpful for those things. And the other thing that medication tools we do think can be helpful, that we can use, you can have a tool in your tool belt to help with if there's a problem in this area, is sleep. So you can consider medications as an adjunct to treat the other underlying or comorbid conditions, once you're able to kind of suss those apart, or if there's sleep issues. So my approach to medication is generally phase 1, try to get them into therapy. And then I am going ahead and addressing sleep if that's an issue. Of course, first with sleep hygiene, addressing trauma triggers at night, but we'll consider melatonin if you're doing those things and still struggling, and consider a trial of an adrenergic modulating agent. My favorite for this type of scenario is clonidine. Guanfacine is another good option. Occasionally, sometimes using prazosin. A lot of pediatricians and primary care providers are comfortable with clonidine and familiar with it, using it for kids with insomnia related to ADHD. So it's something that can really help calm things down to be able to get a good night's sleep. And sleep, we know, is so important and have downstream effects on mood regulation, on attention, on behavior. So it is okay to go ahead and try to address sleep first behaviorally and second with medication while you're trying to get them treatment for their trauma-related symptoms more specifically. And then as you continue on, you're getting them plugged in with therapy, you're fixing the sleep. If other types of symptoms are still there, it may be easier to separate them from trauma-related symptoms and then go ahead and feel comfortable treating those now what we're thinking as comorbid conditions. But in general, be conservative, try to limit complexity. If something's not working, stop it before trying something new. And of course, we're using informed consent process, sometimes with proxies if needed and indicated, asking about kids about their thoughts and feelings about these things in a shared decision-making process. So to go back to our case real quickly, we had the 7-year-old girl. She's really angry, not listening. Does she have ADHD? So we do a screen. Has there been a trauma exposure? Well, yes, the caregiver says that they didn't disclose exactly to them, but they were removed from the home due to confirmed abuse. So they don't know what it is, but yes, there has been a trauma exposure. Do I need to report it? No, not in this case. No new trauma is disclosed. And is there suicidality in a 7-year-old? It can be hard to know. You can ask in a developmentally appropriate way, like, have your feelings gotten so big that sometimes, you wish you would go to sleep and not wake up, or thinking it'd be better off if you weren't alive. And you can ask caregivers if they have safety concerns. And in this case, kid didn't answer when we asked that question, and parents didn't have any acute safety concerns. So then we go on to, okay, what do I do? How severe are the symptoms? How severe is the functional impairment? And in this case, the caregiver filled it out and just eyeballing it, not even having to add up the score. As I said earlier, you look at it and you can tell most of these are marked on the right side. So this is a case of severe symptoms. So we're in that severe symptom stage. And what do we do? For level 1, psychoeducation, anticipatory guidance, and coping skills, and we're doing our best to refer her to evidence-based treatment for pediatric traumatic stress. So finally, real quickly, takeaways. Most children will experience a traumatic event. A minority of those will develop symptoms, but it's especially common in at-risk populations and kids in foster care, unhoused, developmental delay. Screen for risk factors so we can help prevent, screen for trauma and at-risk kids and any kind of mental health complaint so we don't miss it. Consider using a rating scale to help triage for treatment. And if you're just doing education and addressing safety, don't say, don't feel like you're not doing anything. It can feel like that. That's doing a lot. And it can take time, but those are the foundations of recovery. Stabilization, education so that parents and loved ones can help kids with trauma processing and reintegration. So these are some additional resources I already talked to you all about and my references. And real quick, I'm gonna make a plug to call CalMap at any point in there in that pathway and you have a question, you're not sure, is this the one I should use clonidine about? I've never used that with having lots of nightmares. Should I consider prazosin? This is something that you can call us about anytime. I could say anytime, Monday through Friday, 8:30 to 5:30. You can call us and this 1-800 number, you can do it through the portal. If you're having trouble getting kids connected to a type of mental health treatment, either psychiatry or a specific type of therapy, ask for care coordination. This is where our care coordination team can reach directly out to families, help connect them to resources that they need. This has been a webinar, and we have some upcoming awesome webinars that I hope you all will be able to attend as well on autism and early childhood, on ADHD, and the other types of series we do as a Project Echo series. And those are more case-based and interactive. One next week or a couple weeks from now on autism, and in October on anxiety, and the school-based echoes for school-based health providers are on the third Monday of each month, and we have a couple coming up as well. So for CME credit, thank you all for coming, and hope you can take advantage of the free CME credit. And these are a couple ways that you can do it. You can, if you're you can text if you're the first time, if you're texting attendance, you have to pair your number to your account. So you can text your email address to this number and we'll mark your attendance. You'll be able to receive notification and being able to access that CME. This barcode is another way that you can register your attendance and get CME. And I think that's it. I think we have about 5 minutes or so now for questions, and welcome to stay afterwards for any questions as well. And really appreciate you all coming and yeah, thank you so much.
Thank you, Dr. Cox. Do you mind going back to the QR slide, just so as people may still need to?
Yeah, of
So
course.
you first link your phone, and that's a one-time thing. So the first time you do this, you'll need to link your phone, and then after that, you'll just be able to scan the QR code with your phone. So this was great. Some questions came in. The first one is regarding using the SEEK screening form. Are parents open and honest with the answers? How reliable is it?
Yeah, it's been validated. It's so I know it's been tested and a lot of times and is a helpful tool. Now, is it perfect? No. Yes, there's going to be some families that it's a difficult thing to talk about or to admit. You'd ask, one question is about discipline techniques, right? I think one of them is, have you ever felt like you needed to or actually used physical punishment to discipline your kids? And so a lot of families might feel uncomfortable. And that's where your relationship with families can come in and just getting to know them and them trusting you that you're someone that's on their team and how you're communicating with them. But it is, like I said, it's a really helpful tool to just kind of use for everybody so that we know we're not, oh, I don't think anything's going on with them, so I'm not going to ask, we're not missing stuff that we could be catching. I'm going to go back to, I think I see in the text, there's
and
phone number.
the number is also in the chat as well for the phone number to text. And then we also a question about with the PTSST questionnaire, does that ever cause suggestive thoughts to older kids who self-report?
Yeah, I think that's been always the thing that we worry about with asking about suicide too. If I'm asking about suicidal behavior or self-harm, is that something that is going to cause it? What we've seen over and over is that that fear is understandable, but has not been founded, and we haven't seen that it causes or leads to an increase in thoughts of suicide for suicidality, or in this case for symptoms of PTSD. So I know that's a worry, and I think it makes sense to worry about that. But I think that the downside, though, then is letting that get in the way and missing cases where kids are really experiencing symptoms and we're not catching them. And of course, there's a lot of kids that are experiencing symptoms and we're not catching them. So, but that's a good question.
And then we had a couple questions about elaborating on the process for accessing care coordination.
Yeah, thank you for that. I know that's, a lot of times we hear like folks are, like, yeah, this is great. I would love to get my kid evidence-based therapy or my patient's evidence-based therapy for PTSD, but how do I do that? And needing additional help. And that's where again, our care coordination team, I really couldn't make a stronger plug for them is we're here and available to help. And what you do is, it used to be you had to go through calling our psychiatry consultants, like calling me or Lauren and saying, I think I need some help, or maybe we would identify that you might need some help. But now you can you can ask for care coordination directly. You don't have to go through our psychiatry consultants. When you place a request, either calling our 1-800 number, or you go to or you go through the portal, through the website. There's a way you can either tell someone when you're on the phone, or on the portal, you can select care coordination. And that will go down that pathway, and someone will reach out to you to then schedule a time to talk with someone in our care coordination team. They'll call you, talk to you on the phone, make sure they have all the information, maybe be able to give you some tips on kind of things that you could try first. But if there's significant barriers, you've tried the things that they're already thinking of, what they can do is actually reach out directly to families if you've already gotten their permission, and they can call them and say, talk to them and call these programs with them. They can help them help advocate for them through the school system, through their insurance company, again, to make sure that we're able to connect them with the care that they need. Yeah, really good question and important.
And let's see, it looks like we've got questions about, so one question is about the upcoming virtual sessions. I added the schedule in the chat. You can also go to the CalMath website to see that as well. And maybe Joe, if you don't mind navigating back for a moment. So this is the upcoming schedule. And keep an eye out for our newsletters as well in your email that will announce upcoming echoes and webinars as well. And okay, and then with the, we'll take a note in the chat and also reach out if we'll try to do our best to help with the CME issues. The number for care coordination is going to be the same as the CalMath number, I believe.
Yeah.
So that is 800-253-2103. It's also in the chat, and also if you go to the website, it has both the option for using the online form, or you can always use the phone number, which is listed on the website as well.
Well, thank you all so much for joining, and thanks for doing this work that you're doing. And give us a call if you ever have any questions or need any extra help. Thanks for coming.